of all, every patient that we assess is typically coming from the conventional route, almost universally. And so with that standpoint, we have to review their history, see, what is their clinical indication, where are they in the treatment and process, and where are they in the progression response curve, if you will, of treatment outcome. And so with that, we have to identify 3 areas. Number 1, is there a tumor to target? Number 2, can we help the person? And that's by engaging the immune system. And 3 is the patient healthy enough to travel? If their quality of life scores, ECOG scores, are so that they can't travel, they have brain metastasis, they have active pulmonary embolus, these are going to be patients that we do not accept as patients. But if there's a tumor to target, if there's the ability to engage the immune system, whether that's standalone or in conjunction with conventional therapies, we're going to do that. And so we meet with the patient via Zoom, we evaluate their imaging, we evaluate their labs, and we meet with the patient to see if we come to alignment with that. Now, when you look at the conventional oncological approach, surgery, chemo, radiation, all of those are very much born out of the war mentality of going to attack on the tumor. And what it does as a byproduct of that, per the research, is it can do great damage to the immune system. And so it disengages the immune system. And so what we want to do is re-engage the immune system. After all, that's the body's defense. And though you can create destruction to a tumor, you can't create long-lasting, durable immune response, immune memory, without engaging the immune system. And so the cancer is already creating disruption and dysfunction within that. So that history of what chemo, radiation, surgery has been done, even newer targeted therapies and even systemic immunotherapy, it gives us a perspective about what kind of exhaustion are we going to be seeing from the immune system? Are we going to be seeing an immune system that's set up for T cell exhaustion, NK cell exhaustion, dendritic cell exhaustion? And so what's going to be our approach to help this patient, and can we help them? Let me talk about a flagship integrative therapy, IV vitamin C, okay? I've been talking about that a long time. It's the most, I would say, misunderstood integrative oncology therapy out there. And the reason is because the way medicine and the way conventional oncology has looked at almost every therapy, it's a zero-sum game. It is pro-oxidative or it is antioxidative as it relates to vitamin C. There was a very nice review article just published, but what they were doing was reviewing vitamin A and vitamin C as it relates to its pro-oxidative and coexisting use with radiation, okay? And so they looked at preclinical and they looked at clinical, and that in clinical, that included phase 1 and phase 3 studies, looking at pancreatic cancer, ovarian cancer, and melanoma. And what they found with vitamin C, as what others have also seen, and this was also shown preclinical, is that the vitamin C, when given physiologically, classically that's oral because you can't get enough vitamin C into the systemic circulation to be pro-oxidative. It's typically only about 200 to 400 millimolars, micromolars, and you have to get that to 1,000 micromolar and really 20 to 40,000 micromolar to be pro-oxidative. But what this review showed is what these studies conclusively showed is that you can give pharmacological IV vitamin C that's directly pro-oxidative, and it is augmentive, synergistic with radiation, which by its technique is also pro-oxidative. But here's the beauty of what it does. It actually is antioxidative simultaneously to non-cancer cells. So when you look, for example, at the immune system, which is what we do at the Williams Cancer Institute, if somebody's receiving radiation, say they have bone mets or say they have brain mets, okay, this review included a phase 1, phase 3 looking at glioblastoma. You are going to improve temozolomide with the vitamin C and its impact, quality of life measure, at least in this study, in this patient with these patients with glioblastoma. But by doing that with the radiation, you're going to improve the cytotoxic anti-tumor effect. But at the same time, your immune cells desperately, particularly your lymphocytes, desperately need vitamin C. So by giving vitamin C IV, you can augment a conventional therapy like radiation, not be antioxidant with the tumor. The two different environments by the same treatment are different. It's different. And so you can augment the immune cells, but at the same time, augment the radiation, protect the healthy cells, immune cells, and augment the destruction of the tumor cells via radiation. But it also protects against the cancer cell trying to repair the damage done by the radiation. So it's really here, this is just a recent review, but it's reviewing preclinical and clinical studies showing that a flagship integrative oncology therapy can be used to protect healthy cells. In fact, I would say boost them in the immune system and also augment radiation. I'll touch just a little bit quicker on vitamin C and we'll jump over to some other things. But vitamin C also been showed is a study at the University of Iowa, augment chemotherapy in pancreatic cancer, increase survival, doubling it. So, that right there are studies showing that these integrative therapies can be used alongside in conjunction with the targeting of tumor and the protecting of healthy cells and actually improving outcomes. So that's right there. And other researchers show that vitamin C reduces side effects from these therapies as well. What we do is intratumorally, obviously. So when you look at pulse electric field therapy, it's our ablative technique of choice where we go into the tumor, basically introduce nanopulses of high voltage energy to destroy part of the tumor. Animal studies and preclinical studies have shown that when you do this prior, whether that be intratumoral PEF or even intratumoral immunotherapy, prior to surgery or prior to chemoimmunotherapy, you improve the immunotherapy response and you reduce metastatic risk and cancer recurrence. So what that's telling me is when you look at the conventional surgery, chemo, and radiation, which damages the immune system, if we engage the immune system first, then what we're going to do is bring the immune system, quote unquote, to the fight before we lead to potential damage with surgery, chemo, and radiation. Now, surgery, chemo, and radiation have their purpose. Okay. If you have brain mets, we need stereotactic radiation. If you have bone mets and you've got pathologic fracture, we need that. Okay. Sometimes we need surgery to reduce tumor burden. But if we engage the immune system first, the body's defenses, we're going to get better in these animal models, lower metastasis and lower recurrence and better outcomes. That right there tells me that what we're doing intratumorally by engaging the immune system elicits better outcome. But we need that in conjunction with conventional, the chemotherapy, the radiation, etc. I would also bring into, the gut microbiome. And this is a vast area of which we know so little about. So, for example, when you look at the My Baby Biome research update that was published here not too long ago, finding that 92% of these children at 2 years, they were recruited at 3 to 7 months, about 412 patients, they found that 92% of them had significantly declining or absent Bifidobacterium infatis. That is a particular genus species of bacteria. Now, why is that important? You can't prime the immune system without that. They are seeded through vaginal birth and breastfeeding. But within 4 to 6 weeks, 90% of the gut microbiome of a child is dominated by that, and that dominates the immune priming. When you remove that, studies tell us you increase metabolic dysfunction, obesity, systemic inflammation, autoimmunity, cancer. So it's not only a prevention, we are using it through fecal transplantation to actually immediately impact the gut microbiome to actually improve immunotherapy. So when you look at certain gastric cancers, when you look at melanoma, renal cell carcinoma, where they've actually given fecal transplant from a responding patient, meaning a patient that was undergoing systemic immunotherapy and they responded, they then took the gut microbiome from that patient, they then implanted into an individual that was a non-responder. It's a light switch. It engaged the immune system, but it's the gut microbiome that did it. So what that tells us is that when we're engaging the immune system, we need to aid and bring the gut microbiome to that. And the best way to do that when cancer is actively diagnosed, it's fecal transplantation. But I'll tell you, it even augments chemotherapy. It augments radiation and it reduces side effects associated with chemotherapy. So again, when you bring these therapeutics as the evidence is advancing and accelerating, like the gut microbiome, like vitamin C, like intratumoral PEF, like intratumoral immunotherapy, what we're doing is we're making what conventional oncology is doing better, safer, but the way we're doing it is we're engaging the immune system. You don't have to wait for it. You don't have to hope for it. It's available today. Now, that doesn't mean you do no surgery, you do no chemotherapy, you do no radiation. What we hope is you do less, okay? And it's more effective. The reason why people fear the diagnosis of cancer, yes, it's the word, but it's what their life is about to look like, what they're about to live through. That is what evokes fear. I would actually say that word evokes more fear than mortality and death itself. But it's that experience that they want to avoid. And by bringing the immune system into it, we believe that you can avoid that, but it's by doing it on the front end. And, so from our perspective, it's about turning cold tumors hot. So much of what we have in the oncological field right now is how do we take non-immunologically responsive tumors, irregardless of whether they receive surgery, chemo, and radiation, how do we now make them immune hot, meaning immunologically responsive? And fecal transplantation, fasting, intratumoral PEF, intratumoral immunotherapy with CD40, with CPG. These are just a few examples of what we can do to take a non-immune responsive, maybe even an immune desert where there's no immune cells there at all, which is roughly about 25% of solid tumors per current estimates. But if we just did dietary changes, fecal transplant, intratumoral PEF, we are now taking a non-immune engaged environment in the tumor microenvironment, and we're engaging the immune system. And I think the perspectives of what's possible definitively change when we bring the immune system in from the get-go. Now, the research is only starting to look at this, but I think what we're going to find is the more and more we engage the immune system, the earlier and earlier we engage the immune system, and whatever technique that is, which I believe fecal transplantation must be an integral role in so many aspects of cancer, not all, but probably most, and then bring the immune system through intratumoral approach, I think our outcomes and our perspectives and our possibilities change.